My name is Claire Lawlor. I am a pediatric otolaryngologist at Children's National Medical Center in Washington, D.C. We have an affiliation with George Washington University School of Medicine. I did my residency at Tulane in New Orleans and my fellowship at Boston Children's Hospital. And I have now been in practice for a year and a half, coming up on 2 years, I guess. So I'm going to talk to you all today about dysphagia and laryngeal cleft. Dysphagia is everyone's favorite subject. Everyone finds it really interesting, I know. It's a little sarcasm there, but I'm specifically focusing on the pediatric side of dysphagia. I have nothing to disclose. So briefly, what we're going to do today is we're going to go through what a normal swallow is, the epidemiology of dysphagia, what can cause it, how you work it up, and then how you treat it. And then specifically, I'll get into laryngeal cleft at the end. So normal swallow consists of 4 phases. The preparatory phase develops around 6 months of age, and that's within the oral cavity, the preparation of the food that you eat into a food bolus. In small babies, that's sort of the suck reflex. The oral phase is a soft palate elevation, and it prevents food from regurgitating into the nasopharynx. The pharyngeal phase, the velum approximates the pharyngeal musculature. The larynx elevates and the vocal folds adduct. The tongue and pharyngeal muscles then propel the bolus into the pharynx. In the esophageal phase, the cricopharyngeus muscle relaxes and the food bolus enters the esophagus, where you get coordinated smooth muscle peristalsis to move the food bolus into the stomach. Development of the suck in utero can begin as early as gestational week 10 or 11. By gestational age 34 through 38 weeks, if a baby is born, they're typically able to oral feed. Prior to that, if you have a more premature baby, they often need feeding support. In infants, all 4 phases of the swallow are under involuntary control. In children and adults, the preparatory and oral phases are voluntary, and then the pharyngeal and esophageal phases are involuntary. A physiologic swallow is the result of the coordination of more than 30 nerves and muscles, so it's very complex. An insult at any level, starting from the brain, going down through the more fine anatomy in the oral cavity, oropharynx, neck, esophagus, etc., can disrupt a normal swallow. And it's always important to distinguish a functional swallowing difficulty from something like a oral aversion. The epidemiology of dysphagia, the incidence is estimated to be about 0.9% of kids. However, it's more prevalent in certain children who are higher risk, and I'll get into some of those higher risk populations in a moment. Interestingly, about 50% of parents report their totally healthy normal kids have feeding problems, and 80% of kids who have developmental delays have difficulties with feeding. Dysphagia can be categorized based on the disordered phase of swallow, one of those 4 phases that we just talked about. And each phase presents differently. Oral dysphagia can present as absent oral reflexes, immature or absent suck, uncoordinated biting and chewing, poor preparation of the food bolus. Pharyngeal dysphagia can present as laryngeal penetration, where you actually get food going into the laryngeal vestibule, or aspiration, where food bolus passes beyond the vocal cords themselves. You can get obstruction, you can get pharyngeal and nasopharyngeal reflux, and then the esophageal dysphagia results from poor passage of the food bolus through the esophagus, or poor coordination of the muscles. So what causes dysphagia? Prematurity can certainly result in dysphagia. As we already talked, you got to be at least 34 weeks to even have a hope of feeding normally. Usually. So a large population-based cohort study found that the prevalence of feeding issues in children less than 37 weeks was about 10%. Obviously, that's that's higher than the incidence that we quoted before. Very low birth weight infants who are less than 1,500 grams, the incidence of dysphagia is as high as 24.5%. Why do infants have this problem? It can be delay in the development of head control, poor tongue movement, palatal function, gag reflex developmental delay, lack of laryngeal sensation as the child is just maturing. They can also have comorbid pulmonary, central nervous system, cardiac diseases, further complicating dysphagia. And then they can have things like, that we think of more commonly as ENTs, like laryngeal malacia, that can cause swallowing dysfunction. Additionally, some of them end up with a trach or prolonged intubation, and that in itself can delay a normal swallow. Neuromuscular disorders can disrupt the complex coordination of swallow at many, many different levels. Delayed reflex, hypotonia, generalized discoordination can all cause dysphagia. I highlighted cerebral palsy here because that's the most common cause of neuromuscular cause of dysphagia in children. The presentation and the clinical course of dysphagia in a child with neuromuscular disease is determined by the level of insult, whether it's in the CNS, whether it's a peripheral nerve problem, and whether the insult is a static problem, meaning this is how it's going to be for the rest of the kid's course, or if it's a progressive disease, like they could get worse, like a metabolic disorder, etc. GI tract disorders obviously can cause dysphagia. GERD is, okay, gastroesophageal reflux is the reflux of gastric contents into the esophagus with or without vomiting. And that can be physiologic in normal infants. So some degree of spitting up, you may hear babies called happy spitters. It can be normal. It's not obviously normal in children. When there is a pathology associated with the gastroesophageal reflux, even in infants and going all the way up obviously into children and adults, it's called GERD. So that is an important distinction. The incidence of GERD in North American infants is estimated to be between 10 and 20%. The symptoms of GERD, like irritability, failure to thrive, feeding refusal, posturing, cough, stridor, hoarseness, are all very similar to some of the presenting symptoms of dysphagia in infants, so it makes the distinction very difficult. EOE, eosinophilic esophagitis, is an immune-mediated disease linked with food allergies, environmental factors, etc. These kids present with vomiting, choking with meals, dysphagia to both liquids and solids, chest pain, and food impaction, often failure to thrive. You diagnose this on a EGD with a certain number of eosinophils, intraepithelial eosinophils per high-powered field. It's 15. That could be a board's question. And that's a whole nother talk in itself. Cricopharyngeal achalasia, less common, but that's where you get spasm of the cricopharyngeus. You get the cricopharyngeal bar on swallow studies, and they often will have more dysphagia with liquids. And when they swallow liquids, it splashes, and it can splash onto the vocal cords and give them more likely to have aspiration and penetration. Cardiopulmonary disease. The prevalence of dysphagia in infants after cardiac repair can range from 22 to 50%. It can be intrinsic to the cardiac disease itself, vascular rings and slings, obviously, you think about, or it can be related to cardiac procedures, prolonged intubation, etc. If the recurrent laryngeal nerve is injured, obviously you get a vocal fold immobility, and you can have risk of aspiration and dysphagia just from that. They often have comorbid issues like prematurity, bronchopulmonary dysplasia, etc. So you can see how those things are linked together. So what about anatomic causes of dysphagia in children? You break it down from infants to kids. I know there's a lot of words on these slides. I'm happy this is being recorded. You can take time and look at this later. Choanal atresia, obviously those kids, depending on its unilateral or bilateral, they can't breathe very well through the nose. This will, any kind of nasal obstruction in an infant inhibits the normal suck, swallow, breathe. So if they have to work extra hard to breathe, they can lose coordination in their swallow. These babies or children present with stridor, mouth bleeding, rhinorrhea. When you get into oral cavity and oropharyngeal anatomic causes of dysphagia, oral ties and micrognathia, retrognathia, those are big. We're going to talk a little bit more about those a little bit later. But obviously cleft lip and palate, you're not going to have a totally normal swallow. And as you go through the rest of the things, some of them are less common. These kids present with a limited suck, nasopharyngeal reflux, poor oral competence, poor manipulation of the food bolus, and they can have voice changes. When you get to the level of the larynx, we're going to talk a little bit about laryngeal malacia, vocal fold immobility, and clefts. These children present with stridor, voice changes like hoarseness or breathiness, recurrent respiratory infections. Once you get below that, at the level of the trachea and the esophagus, obviously esophageal atresia, TE fistula, we already talked about cricopharyngeal achalasia, tracheobronchomalacia. These kids are presenting with stridor, often biphasic, respiratory distress, regurgitation, again, recurrent respiratory infections, possibly failure to thrive. So the symptom is the symptoms are going to be very varied depending on the cause of the dysphagia. So because we've just shown how many different things can affect swallow and how complex swallow is, these kids can prevent in many, many different ways. The symptoms like stridor, cough, voice changes, since those are all presenting symptoms of dysphagia, those kids are going to end up in your clinic. So especially if you're a pediatric otolaryngologist or a general ENT who's seeing kids. Silent aspiration is something that you have to think about. These are kids who are aspirating, but their sensation is down at the level of the larynx and they don't cough. Irritation of the larynx also can result in bruits and altes. So those alone can be presentations of aspiration. So how do we work these kids up? It's really important that this is a multidisciplinary team evaluation. A clinical feeding evaluation is a bedside test with SLP. They can do lots of different tests. They can do thickeners. It's a really great initial evaluation, especially in kids, because they can tell you which kids can actually participate in further swallow studies. And if it's safe to proceed, because if a child can't take PO, they can't do any like an MBSS or a FEES, etc. Benefits of a MBSS or a VFSS are that it's an objective tool that can confirm penetration and aspiration. If the child won't take PO, you can't do it. If they're not safe to take PO, deemed by prior proof of aspiration, etc., they can't do it. You can't evaluate breastfeeding, so that is a limitation of the test, and it does expose the patient to radiation, so you don't want to keep repeating it over and over and over again, because the fluoroscopy, you end up getting a cumulative, pretty decent dose of radiation to kids. FEES, no radiation. It's more subjective though. They can sometimes be performed by just SLP, but it's often SLP and ENT working together. Put a camera in the nose if the baby won't tolerate or the child won't tolerate that. I have some kids with some pretty severe developmental delays who especially the bigger kids who are about the same size as me, who I just could never ever do that on. You miss out on the oral phase of swallowing because there's a whiteout on the camera as the kid swallows. And you can't really detect micro aspiration. And then when you get into further imaging, you're talking about chest x-rays, CTs of the head, especially if you're looking for a nasal or oral cavity cause of obstruction and an anatomic cause of the dysphagia, MRI, and then obviously you're also considering imaging the chest to look for sequelae of long-term aspiration. And then endoscopies, this is a key part that we participate in. This is often coordinated, again, multidisciplinary team approach. You can do additional testing such as bronchial washings, biopsies, etc. Place impedance probes, usually obviously that's done by your GI colleagues. So this is an algorithm for the management of pediatric dysphagia. You can take the time to look at this. This basically goes through the different aspects of your workup that we just talked about, and then how you manage them. Here's an example of a modified barium swallow study where you can see the barium leaking into the airway anteriorly there, and that's demonstrating aspiration. You can see the esophagus is dilated more proximally, and you're going through the peristalsis of the esophagus there. But the great thing about these is this is a still shot, but it's more of an active exam. Here is an example of a sagittal CT scan in a child who has micropnathia. You can see that significant overjet of the maxilla. This could certainly contribute to dysphagia in a child. So this is where you might end up getting a CT scan. So then how do you manage these kids? Again, multidisciplinary team evaluation. Considering a neuro eval is really important in children who have dysphagia, where you've done the rest of the workup, you've done the endoscopies, you've done the swallow studies, you've confirmed the child has dysphagia, but you cannot identify a anatomic source, so you're going to consider a neurologic evaluation. You can do feeding therapy as your first line approach if the child is safe to take PO based on the studies that you have done. This may consist of altering the means of food delivery, whether that in an infant is changing the nipple flow. In kids, you could change the spoon, you can change the position that the child is fed in to help with coordination of a safe swallow. And obviously you'll be working really closely with your speech and language pathologists on that. You can also do sensory exercises, etc. You can change what the child is eating. You could give them a higher calorie formula or fortify breast milk so that if they fatigue with feeds, they're able to take in higher doses, higher calories in a smaller amount of volume. You can also thicken liquids that they're taking. If a child, let's say it's an older child and they're deemed safe to take solids, purees, you can thicken their liquids. There are tons and tons of different kinds of thickeners, and they all have certain risks and benefits. So that's really important to work with your speech therapist on and figuring out what the safest one is for each individual patient. Reflux regimens are often prescribed by many different providers, ranging from pediatricians, GI, ENTs sometimes prescribe them. This can be a little controversial. You want to make sure you're distinguishing the symptoms of dysphagia from reflux as best you can, and prescribe those safely. And so then you manage the child depending on the etiology of dysphagia. Again, that's the most important thing, is trying to determine in each individual patient what the cause of their dysphagia is. If it's neurologic, you're obviously determining whether or not they need an alternative feeding source, what the safest diet is, etc. But as ENTs, we encounter many anatomic etiologies of dysphagia that we can treat surgically. So I'm going to go through just a couple of those really quickly. Here are some of the most common ones. Tongue tie, hot topic, could be an entire lecture in itself. Perhaps it even has been. Laryngomalacia, vocal fold immobility, and laryngeal clefts. So tongue tie. It gets blamed right now for all breastfeeding issues, it seems like, at least in my clinic. But the difficulty in feeding is often multifactorial. It can be relating to the position of the mandible in the child, nasal obstruction, oral coordination, maturity, maternal factors like mom's nipple shape, breastfeeding position, etc. So I'm not going to get into everything about tongue tie today because there's so much there, but I would just advise you to look at the literature on it and be cautious with your cutting of oral ties. Any other oral tie beside tongue tie, there's really no good data out there to suggest that it really improves breastfeeding. The Academy of Otolaryngology just released a clinical consensus statement on ankyloglossia in children that's worth a read. So we'll kind of move on from that. Laryngomalacia, these are photos of supraglottoplasty. First one looks like it was done with cold steel. The second one is laser. The incidence of dysphagia in patients with laryngomalacia can be as high as 50 to 86%, depending on what studies you look at, and that's independent of other medical comorbidities. It may be related to diminished sensation and neuromuscular tone of the pharynx and the larynx. that is innate to laryngomalacia itself. Increased work of breathing as the airway collapses and narrows with inspiration can also just cause children to fatigue and interfere with an infant's suck, swallow, breathe sequence. Supraglottoplasty can help this, but also you need to be aware that supraglottoplasty can result in new onset aspiration in patients who were previously normal and had normal swallow function. So, you know, be careful there. It can go both ways. This is vocal fold immobility, injection medialization that you can see here. The photo on the left, you can see the left vocal fold has been bulked up. Vocal fold immobility in kids can either be obviously congenital or acquired. It can result in glottic insufficiency, poor cough, aspiration, etc. But not every kid who has a cord out is going to have an unsafe swallow. So if this is something that is diagnosed, it's important to work up their swallow and then also sort of follow them with time, because that cord can change position if the cord is truly going to be immobile forever. And again, it can be 3-4 years before you fully determine that a child nerve function is returned that late in iatrogenic cases. So the right cord, let's say the left is immobile, the right may be able to compensate. And while they may initially have some difficulty swallowing, they may develop a safe swallow on their own through compensation. And then if they don't, what you can do ranges from something temporary like a vocal fold injection medialization, ranging up to thyroplasty and recurrent nerve reinnervation procedures. So that, again, another whole talk in itself. But injection medialization is quick, temporary, fairly well tolerated, and can safely improve swallow in these children. So let's talk now about laryngeal cleft. This is sort of the second part of the talk. We'll give a brief introduction to laryngeal cleft, help with classification, diagnosis, management, and some of the controversies within laryngeal cleft itself. I want you to be able to learn how to diagnose and classify clefts after this, and then become familiar with the management strategies depending on the type of cleft that you diagnose in these patients. So laryngeal cleft was first initially described in 1792, actually. And the first successful repair of the cleft was done in 1955, but a series of more than 20 patients with cleft wasn't published until the 90s. There's a slight male predominance of 5-3, but it results from failed fusion of the tracheoesophageal septum and the lateral growth centers of the posterior cricoid cartilage. It's pretty rare, and it's associated with other airway anomalies and syndromes. If you think about the failed fusion of the tracheoesophageal septum, you can really see how this would be associated with EA and TEF, as well as tracheobronchomalacia. They often present with respiratory and swallow symptoms, such as the dysphagia that we just talked about in the first part of this talk, failure to thrive, and recurrent infections. You need a comprehensive differential diagnosis when you're working these patients up, and you should consider reflux, reactive airway disease, neuromuscular swallowing disorders, so just dysphagia without an anatomic cause. And a lot of these kids, once they finally land in your clinic, will have been treated for something like asthma or reactive airway disease prior to evaluation by us, just because of the lung changes from aspiration. So this is the most common classification scheme published by Benjamin and Andy Inglis in 1989. A type 1 cleft involves an interarytenoid defect to the level of the true vocal folds. Type 2 is partial extension through the posterior cricoid cartilage. Type 3 is an extension completely through the posterior cricoid cartilage with possible extension into the cervical trachea. And type 4 involves extension into the intrathoracic trachea. And you can see that on these diagrams here. This is just a photo, and you can see that of each type of cleft. D in the bottom right corner, that's supposed to be a type 4 cleft. it's really hard to tell where you are because you should be intrathoracic on that one. But A and B are the ones that you see most commonly. Type 3 and 4 you may see, and it's obviously much less common. So the diagnosis is, based on your history and physical. These kids get a flexible laryngoscopy in clinic usually, but you can't diagnose a cleft just with that. With the fees, you can see the penetration of the food bolus into the interaretinoid area. And again, not exposing those kids to radiation, but the modified barium swallow study, again, objective, and you get that with your SLP colleagues. So you're going to be consulting them, often consulting Pulm, GI, and Neuro. Again, this is a multidisciplinary evaluation. But the gold standard for diagnosis is going to be on your direct laryngoscopy and bronchoscopy. So there are lots of different ways that people prefer to perform the direct laryngoscopy to probe the posterior glottis and diagnose cleft. These are photos from a publication out of Seattle Children's, where they recommend the use of this very standardized laryngeal exam with the use of the laryngeal spreaders, to the vocal fold spreaders, to get a better view of the voice box. And they use a hooked probe and they swing it, and based on where the it's usually placed on the posterior arytenoid right at the level of the groove, and they swing, and based on where the probe touches on the anterior part of the larynx, they diagnose the cleft. And they have found some reliability between different surgeons when using this to rate laryngeal cleft. I think this is the use of this method is expanding. I know some of my colleagues use it, but some people still prefer to use a straight probe. They don't use the vocal fold spreaders. Some suspend, some don't. Some measure actually in millimeters the depth of the groove. So lots of different styles there, which can make studying this quite different. So the management for type 2 through 4 cleft, the recommendation is clear. That is considered to be anatomically abnormal, and they should be repaired surgically. From there, whether you do it endoscopic versus open depends on the patient, depends on the surgeon's comfort. Type 1, 2, and 3 have all been repaired endoscopically. I don't believe type 4 going down into the chest has been repaired endoscopically. If endoscopic repair fails, then you can always go to an open repair. The type 1 cleft, this is where you get into the controversy of whether it even exists, and whether you manage them medically or surgically. And then when you repair the type 1, do you use a laser and a suture closer, or do you just inject? And the injection is performed very similarly to vocal fold injection, which we talked about previously. So the goals of the management of your laryngeal cleft is twofold. 1 is to resolve the feeding impairment, and 2 is to minimize respiratory complications. So how do we do this? This is tubeless anesthesia. You want the patient spontaneously ventilating. You want them immobile. You don't want them to feel pain, so you want them to have analgesia. Lack of airway reflexes. You don't want them going into laryngospasm, bronchospasm, etc. You don't want them coughing. You want them adequately ventilated and oxygenated, ideally no apnea, and you want to be able to have a full view of the laryngeal inlet. And you don't want them to respond when you suspend them or have any sympathetic response to your suspension laryngoscopy. Typically, it's done with a gas induction with sevoflurane or nitrous, propofol if there's an IV present, and then usually propofol and remifentanil. This is a study out of where I did my fellowship at Boston Children's. This is what they use. Topical lidocaine is applied to the vocal fold as well. This is going to be your setup. This is the same study out of Boston Children's, Lynn Ferrari and Reza Rabar. They prefer to use a Lindholm. I think Probably some other surgeons prefer to use Parsons or a different laryngoscope. I still use a Lindholm myself. You use the jet ventilator needle to supply 3 to 4 liters per minute of oxygen, not actually for jet. And you have an ET tube ready if you to either intubate through the laryngoscope or pull the laryngoscope out if you get into trouble. Here's a photo of your setup. You take laser precautions. So this is before the child has been draped with wet drapes. Obviously, you want to have all of the sterile water in the room. You want to have laser protection on everyone. Make sure, again, to keep your FiO2 down. This is for the endoscopic CO2 laser suture repair. This is different from injection. You would set it up very differently. You wouldn't need all the laser precautions. These are the instruments that we typically had available when doing a CO2 laser repair. This is a straight probe here. You get these alligators. You want to have your suture holders, scissors you will need, and this is a knot pusher. You can use an OmniGuide or a micro manipulator. Here's a photo of the OmniGuide laser being used for a type 3 cleft. The vocal fold spreaders are particularly helpful when you have a deeper cleft that you're trying to repair endoscopically. So here you can see, oh, where's my mouse? Here you can see the vocal fold spreaders are being used to get to the depth of the cleft, and you start caudally and come cranially. We usually use the settings of 3 to 6 watts at 0.1 to 0.4 second intermittent mode. So here's photos of a repair. You suspend the patient, you denude the mucosa with your CO2 laser, take an Afrin Pledget and wipe that char off. Close caudally to cranially, and you can use Vicryl or PDS is what I have used. People have strong preferences. For a type 1, type 2 laryngeal cleft, it's usually only 2 sutures. For type 3, you can get 3, 4 sutures. You really need to take care to denude the mucosa at the apex of the cleft, because one of the risks, especially with a deeper cleft, that you will get is these little iatrogenic, essentially TE fistulas. If you get partial closure of the cleft, but you leave that distal part unrepaired, you can get a little TE fistula there and have to go back and repair that. Obviously, take very good care when using the laser to not pass point and injure the rest of the airway. So here is a video of a type 3 repair.
So can you see the hole there? Yeah, perfect.
Here you're not using a vocal fold spreader. This is Reza Rabar doing the surgery. This is from my fellowship. And then you'd obviously go repeat that on the other side. These patients have to be able to tolerate, you know, an hour and a half to 2 hours of suspension. So that's obviously a really important, if you're doing a type 3, a really important discussion to have with your anesthesiologist. The type 1s usually take less time than that, type 1, 2. So what if you either fail an endoscopic approach or you don't think the patient's amenable to an endoscopic approach? There are lots of different ways to perform an open approach to a laryngeal cleft. You can do a laryngeal fissure, you can approach laterally, and depending on the degree of cleft, obviously you can go down into the chest. For type 3 and 4, you may need cardiopulmonary bypass if you're going down, obviously, with a thoracotomy, sternotomy, etc., depending on the extent of the cleft. And you may need a trach. It doesn't have to be permanent, but during the surgery, it gets the endotracheal tube out of your airway, and it can allow the area to heal temporarily, post-operatively, by not having to have an endotracheal tube through the site of your repair while they're recovering in the initial postoperative period. You can use grafts, place grafts to support your repair of that tracheoesophageal septum. So you can use SCM. I've seen tibial periosteum, costal cartilage, depends on what you're most comfortable with and what you feel comfortable harvesting yourself. So it's a 2-layered closure. So if you can imagine that this is the trachea and this is, here you can see the cartilage ending. This is supposed to be beyond, obviously, the cricoid, so you'd be calling this either a type 3 or type 4. This is where the normal pars membranacea should be. This is the esophagus. So you, while you're open through a laryngeal fissure approach, let's say you make an incision in the mucosa here and an incision on the esophageal side, and then you close these to each other and these to each other. You can imagine how difficult this is, especially in a really small baby. In between these 2-layered closure, you can place a graft, any of the grafts that we talked about previously. This was described in 2006. Here's photos. So this is a type 3 cleft. This is an esophageal, I think it's a temp probe or a bougie. And so here's the extent of your cleft. The patient has, the airway was removed from this just to take this photo, but you gotta have either an airway here, lower down in your incision, or and turn it into a trach at the end of the case, or a separate incision for your tracheotomy. And here you would do your 2-layered closure right in this area, place your graft, but you can see how difficult that can be. So type 1 clefts, this is where you get into a little bit of the controversy with laryngeal cleft and whether people even believe in a type 1 cleft, or they call it just a deep groove, or feel some people are over operating on type clefts. There's a lot of controversy here, and this is talked about frequently in meetings. But what you really need to do is determine if the patient is experiencing the sequelae of a cleft, and if they are, and they fail medical management, you have to repair them. And if their symptoms are more mild, you can trial medical management. Or I will say, often if you do a direct laryngoscopy for another reason, let's say you're looking for a subglottic or a tracheal pathology, and you palpate the larynx, you may find a deep groove or a type 1 cleft to the level of the vocal folds. On patients who are totally asymptomatic, obviously they don't need any intervention whatsoever. So some of the question is is this an anatomic abnormality, a groove to the level of the vocal fold, or is it comorbid, sort of a deep groove with some kind of underlying dysfunction of their swallow that makes it pushes some kids over the edge, and they need to be managed more aggressively with surgery than others. So the sequela that we're talking about that might push you to repair more promptly would be severe respiratory distress, recurrent respiratory infections requiring hospitalization, failure to thrive, or comorbid conditions. So what's medical management? You can use anti-reflux medications. Again, that sort of goes with what we talked about earlier. You want to be cautious with those. Feeding therapy is very, very important. Thickeners, and often children will be put on medical management for somewhere between 3 to 12 months prior to formal repair being done, if the patient can tolerate medical management for that long. And multiple times you will try potentially to wean thickeners and see if the child is improving on their own prior to any intervention. There was a International Pediatric Otolaryngology Group publication about type 1 laryngeal clefts. A large number of pediatric ENTs on that publication, and the range for duration of medical management in a type 1 cleft was, again, 3 to 12 months. If a child has been on, let's say, 9 months of medical management, and you've tried to wean the thickeners and they're just not improving, still having respiratory infections, that's when you would decide to intervene surgically. And then you want to treat any comorbid conditions like reactive airway disease, EOE, etc. So another controversy within management of type 1 laryngeal cleft is injection versus CO2 laser repair. There's a lot of publications coming out on this, especially I know Chris Hartnick at Mass Eye has published a fair amount on this recently, both short-term and long-term outcomes with injection laryngoplasty. This is clearly a much quicker procedure than using the CO2 laser, but again, depending on what your injectate is, it's a temporary. Some kids can just tolerate one injection laryngoplasty and then they never ever need anything done again. That tends to be the minority. And then some you'll do this at the time of diagnosis. So you're doing your DL, you know the child has feeding difficulties. Instead of trialing them on thickeners, diet modification, etc., for 3 to 12 months, you might just do a temporary injection right at the time of diagnosis and see if that fixes their problem. If that fixes their swallow and they then subsequently have a safe swallow, confirmed either with a FEES or a modified barium swallow study, then that has been used to diagnose that the laryngeal cleft was in fact the cause of their swallow dysfunction. And so maybe then those children are more likely to benefit from a more permanent procedure such as a CO2 laser suture repair. This is also an option if you have a child who cannot tolerate an hour of general anesthesia and suspension without an endotracheal tube, or whose neck or oral cavity anatomy is not amenable to suspension with a good view of the larynx. So that's another indication to use injection. You're injecting the same stuff you would inject in vocal fold, calcium hydroxyapatite, carboxymethylcellulose, hyaluronic acid, gel foam, autologous fat, all of that has been described. So we talked about a little bit of this already, just in the prior slides, but these are the big controversies surrounding type 1 laryngeal cleft. Just to briefly mention postoperative management, whether these kids need to go to the ICU or to the floor, how long they're admitted, how long they're on antibiotics, when you repeat a swallow study, all of this is very surgeon dependent. So it's pretty not standardized from institution or even within institutions. I'm all done. Does anyone have any questions? Seems like no. Here are my references. So I know I'm a little short. I believe there's another lecture at 11. I guess you could theoretically start it earlier if everyone was available. But I'm all set. Thank you all for having me.
Thank you so much.